would be okay if you're there, and then we could call you later on so that you can see the presentation. So, good afternoon, everyone. Right, we are at the time, so I'll get started. So thank you all for joining this Community Connect session, which is titled A New Approach to Accelerate Research and Close Gaps in Access to New TB Drugs for Children. I'm one of the co-chairs, and I'm happy to introduce Jacqueline Wambui from Kenya. She works as a global CAP facilitator for the Afro-CAP Treatment Access Partnership. She has an educational background in HIV counseling and training. She is an HIV positive treatment and prevention activist and a TB survivor, and has a special interest in advocating for rights of HIV positive people, and comes with a 10 years or more experience in HIV TB reproductive health programs from Kenya. So thank you, Jackie, for co-chairing this session. Quick introduction for me. I am Dr. Mandar Paradkar. I am trained in pediatrics and public health, and I'm affiliated with Johns Hopkins Center for Infectious Diseases in Pune, and I'm based at BJ Government Medical College in Pune. So just some housekeeping announcements. So we'll have 6 minutes for each presentation by 4 speakers, and there is a timer, and Jackie would be giving 1 minute reminder, last 1 minute reminder as well. The Q&A session will be in the last 15 minutes. Request you all to use the QR code that is over here or on those columns to post your questions on the Slido app, and feel free to use the mic if there are any direct questions. So the 4 distinguished speakers will describe the global burden and key issues for children with TB, discuss the impacts of access gaps on children and their families, and then present key actions that can be taken to better address the child and adolescent TB. And lastly, propose a new approach to studying the next generation of new TB drugs in children. So without further delay, I would like to call Maureen Sekade from Uganda, a technical advisor to Ministry of Health for National TB and Leprosy Program. Thank you, Maureen, please.
Yes, good morning to you all, and it's exciting to be speaking to the community group. I must say this is my first time to really interact with the community group, so I have no conflict of interest to declare, and I'll be talking about the global burden and the key issues with TB in children and adolescents. That is the order of presentation. So we are all aware we are working towards SDGs, SDG 3 particularly, and that's where ending the epidemic of TB, HIV, AIDS, and malaria falls. And with this, we had the recently concluded roadmap for ending TB in children and adolescents that has been replaced by the 3rd edition, which was launched yesterday, and the 3rd edition presents key actions, 10 key actions that we can all use to speak louder for child and adolescent TB. You probably have seen these figures. Out of the estimated 10.6 million people with TB, we had 1.3 million children aged 0 to 14, and 47% of these were under 5. Yes, we have registered progress, but we are not yet there. So this figure just highlights the trend. As the world, we've been able to register cases way higher than what was there before COVID. This is the highest that has been registered. But we still have a very large treatment coverage gap, and this is the largest among children 0 to 4 years. So the red represents the gap, while the blue is what has been notified. So if you compare children under 15 to those above 15, you see that the children have the largest gap, and those under 5 are hit most. Achievement for the UNHLM targets, the children actually did not we did not meet the targets for children, but again, the gaps were higher in the same population. We similarly have registered slower progress for uptake of a preventive treatment among household contacts, and children continue to lag behind. This has also been demonstrated in the analysis on progress towards achieving the UNHLM targets for TB. So broadly, for children, for case finding, TB treatment coverage, the children are lagging behind, as well as the adolescents. So what advances do we have in the space of managing TB in children and adolescents? A lot of progress has been made. We have updated guidance that really provides countries with opportunities to cover the gaps. We've seen advances in screening and diagnosis, digital technology. We have child-sensitive sputum collection methods, and we are now, the world is now taking up a stool, but there are other methods such as the oral swabs, pharyngeal swabs. So the testing platforms have also increased, and we also have some guidance on treatment decision algorithms. There's shorter treatment regimens for both drug-susceptible TB, multi-drug resistant TB, and TB preventive treatment. And the child formulations, friendly formulations, are available. There's no reason why children shouldn't access these. We also, as a world, we've also registered progress in TB infection testing, which is also useful, especially for household contacts or close contacts above 5 years of age. So what are the gaps in TB care? So I'll start with the program-related gaps. These include policy practice gaps. The guidance is there, but translating policy into practice is quite challenging in many countries. The no-do gap is very, very visible as we visit the different countries. We also don't have age disaggregated data that kind of masks the challenges that are faced by the different age groups. There is a limited prioritization and accountability for the child and adolescent TB response. Many times this is integrated into the overall TB response, and the children and adolescents do not get the attention they deserve. We've also noted a vertical programming. TB programming has been, implemented in a vertical manner, and yet we know that for children and adolescents, there are other programs that really are entry points for their care. So there's need for horizontal programming. Focused funding is limited, as well as health worker capacity and service delivery. On individual-related basis, there's limited awareness and knowledge specifically about child and adolescent TB. There's a lot of published literature. Caregivers, communities do not think that children or adolescents can get TB. Stigma and discrimination is a very critical component, and if you have attended the sessions where the TB survivors have presented, you'll appreciate that these are very critical areas for us to address. Access to TB services is also limited, especially for the children. They're not able to produce the samples, so they have limited access to microbiological testing. Adherence is another gap, and this is key really to ensure that children, adolescents are successfully treated. In the space of the disease, we don't have an effective vaccine, and also the optimal microbiological testing methods are limited. So does the community have a role in addressing these gaps? And it's a big yes. Advocacy, communication, social mobilization, awareness, demand creation, and health education. Treatment literacy is very important. Community activities, stigma reduction, and community-led monitoring. And in conclusion, there's documented progress. However, we still have a lot to be done, and the community has a key role in addressing these gaps. Thank you very much.
Thank you, Maureen, for that insightful talk. Next up is Blessina Kumar. She is the head of the Global Coalition of TB Advocates and has training in nursing, midwifery, health system management, and advanced TB diagnostics and research. Please.
Good afternoon, the faithful few who, decided to hang on till the end. I have no conflict of interest. So I just want to start off with a slide that I also shared in the plenary yesterday about children and the pathway from pre-cough to actually getting back on track. With children are there in the community, so is the bacteria. Children develop cough, children get diagnosed, treated, complete treatment, and they're back in the community. That's what we think. But actually, it doesn't happen like that. There are many, many challenges along that pathway. It gets very complicated. The arrows get, they go in every direction, and the challenges are so, so many. There's lack of knowledge and awareness in the community, so there's confusion when children develop cough. Just yesterday, I shared about one of our TB champions who passed away yesterday morning, a young woman in her early 20s, MDR TB survivor, came to Delhi because she developed cough again and for treatment and was shunted from different hospitals. We asked her to go to a TB hospital, and from there she was sent to the All India Institute of Medical Sciences. And then yesterday morning she passed away. So it's not as easy as we all think it is. Even after being diagnosed the first time with MDR-TB, getting treatment and getting better, next time you get a cough, people really struggle to diagnose. Then there is real lack of community-friendly information out there for communities to understand TB and the science of TB and everything else that is associated. There is a high cost. Nutrition continues to be a big problem. A recent fantastic study that was done called the Ration Study based in India, published in the Lancet, really shows how you can reduce the study shows that you are at so much less risk if you have good nutrition, almost cutting down the possibility of infection by 35 to 45%. The mental health, children and adolescents really go through a lot of mental health issues. Many countries have direct bank transfer, but from experience, we know that it actually doesn't reach the people. Diagnosis continues to be a challenge. Children and adolescents miss school. Medications, some are available, some aren't, but access is continuing to be a huge issue. So you see that it's not as easy as we think or as easy as it should be. So there are many, many gaps. And, there are access gaps and barriers in the landscape. And I've tried to sort of, very similar to what Maureen has done, trying to categorize them. In the medical side, if you look at it, there is slow progress. And if there is progress and excitement of new tools, there is very slow implementation. When you know that something good is available and yet you don't have access, that can be an extremely frustrating journey for people who are going through it. Or if only some people get it because they're part of the study, and the others don't get it, it's really a question of ethics and how we should really be responsible in ensuring early access to treatment regimens and diagnostic tools at the earliest possible. There is lack of accountability even within the medical fraternity. DRTB continues to be a challenge. The urgency doesn't seem to be recognized, and there's so much of complacency, so much of laid back sort of an attitude. And TB preventive therapy, which we know can actually make a huge difference, continues to be far from the reach of people who need it most. When we look at the technical side, we still need more tools. Again, there's slow progress. And many times the excuse that, not excuse, I think it's a justified reason, is that we don't have the resources. Yes, we need funding, but also we need accountability in how we spend the funding and who is spending the funding. So bottom line is that we need new tools and technology to move us along in this TB journey. Procurement. I come from a country where this is a huge challenge. It takes years. So every time I go to my NTP manager, he says, "Oh, you don't understand the process." I said, "I understand the process. You don't seem to understand that lives are being lost even as we talk, and they don't care for that kind of language." The costs continue to be high. Again, there is lack of accountability even among the researchers and developers. When we look at the social side, stigma and discrimination, like Maureen has already talked about, continues to be a huge barrier. And GCTA in 2018 came up with a little book on stories of children, parents, and caregivers who talk about the stigma and how it has actually been a huge barrier to accessing care and treatment for TB. And again, we have the evidence now. The rations trial has shown us what nutrition can do. So there's no reason why that should continue to be a barrier in the pathway. And again, lack of accountability across the board. When we look at political, I know a lot of people say there is political will, but translating that political will into action is something that we still struggle with. India is one country where we have the commitment from the highest level. Our Prime Minister himself saying that we will end TB 5 years ahead of everyone, which is around the corner, 2025, but we still don't have the tools and the treatment needed for that to happen. And we need bolder policies, and of course, nutrition also has to be a political agenda for people to move that forward. So yes, children and families are affected. Lack of information and awareness, lack of clarity, stigma, discrimination, delayed diagnosis, increased suffering, increased mortality, increased catastrophic costs, poor health-seeking behavior that becomes multiplied, and lack of ownership. When communities, families don't have ownership, they really feel like treatment and care is something outside and do not seek help as soon as it's needed. So engaging with families and community is extremely important because it's a win-win for both. It needs to move beyond the narrative of just looking at communities, children as recipients of care, but to a more valuable partnership. Better buy-in from the community and families means better ownership and better results, and better understanding means buy-in from the community. And lastly, and again, appealing for price reduction for diagnostics that can be accessible. affordable, and, it is a question of ethics and responsibility in offering what is needed so that we can end TB together. Just shouting end TB is not going to make it happen. It needs actions. Thank you very much.
So much, ma'am. Great presentation. I would next like to invite Dr. Sabine Verkoel from Geneva, Switzerland. She is a medical officer focusing on child and adolescent TB in the TB vulnerable populations, communities, and comorbidities unit of the Global TB program at World Health Organization.
Much. Thanks very much for the opportunity. So, let's see if it wants to work. So I don't have conflict of interest. I'll be talking about the new roadmap, and you've seen already some graphics from that, so hopefully that will help me to go through the presentation in 6 minutes. So just to give you a little bit of history, we had the first roadmap 10 years ago in 2013, and that was the roadmap for childhood TB, and it was called Towards Zero Deaths. And then that was really the first time that we had such a document that outlined what needed to happen to reduce mortality, especially in children, and to address TB in children in general. Then in 2018, we published the second edition. And of course, this is a process that happened, the development of these roadmaps, with input from a wide variety of partners, many of them united in the Child and Adolescent TB Working Group. In 2018, the focus on adolescents was added, with alignment with the targets and commitments of the first UN high-level meeting. And then now we have an updated roadmap, still focusing also on adolescents, and all aligned with the targets and commitments of the second high-level meeting. So again, with a lot of, you see all the logos of the organizations who have contributed to these documents. So Maureen has already taken us through a lot of the data that you can find in the roadmap. So there's a two-page infographic with all the information about burden and mortality, treatment coverage, trends in notifications, also on prevention, treatment outcomes, TB HIV, as well as MDR and rifampicin-resistant TB. So these data really show us where we are currently, and it will sort of highlight, they sort of highlight the gaps that we're having. And for this presentation, I'm focusing on the research and development aspects that are in the roadmap, especially because Tony will be talking about an approach to improve on the R&D aspects. So we have a lot of progress that is all highlighted in the new roadmap. The data from the SHINE trial that informed a new recommendation on shorter treatment of children with mild, non-severe forms of TB. Then we also have projects funded by Unitate that generated important evidence that also informed guidelines and operational guidance that was issued in 2022 by WHO. We have many multi-country collaborations around research on TB in children, and we're getting more high-quality evidence. Then we also have the CHEETAH task force, and Tony will be talking about that. And data are also being generated to evaluate computer-aided detection using chest X-ray in children and adolescents below 15, because we do have that validated for ages 15 and above, but we don't have that for the younger ages. We also have a generic research protocol developed by the TDR and WHO to support the evaluation of the treatment decision algorithms that are included in the operational handbook. These approaches really help to build confidence at the primary healthcare level to make a decision for healthcare workers, by healthcare workers, to start children on TB treatment. And then we are evaluating novel TB vaccines, also targeting adolescents and young adults. These are progressing from phase 2 to phase 2 and 3 trials. And then we also have a drug-resistant TB platform with data, individual data on children and adolescents, as well as pregnant and postpartum women, linking them to how well their babies are doing. That has also been established. But we also have a lot of gaps and challenges. We still have the tendency to exclude children, adolescents, and pregnant and postpartum women from research, which really leads to delays in them being able to benefit from these advances. Also, the performance of diagnostic tests are not great, and the sensitivity is not good. Children have very few bacilli, so you need different tests that are much more sensitive. And also we need to find more child-friendly ways of collecting specimens. We also need additional evidence on those treatment decision algorithms to really improve that clinical approach. And as I was saying, we need more sensitive point-of-care diagnostic tests. Then the chest X-ray, the computer-aided detection, we really need data on that. Also, in many settings, especially in high-burden countries, access to chest X-rays is quite limited. Then, in order to have new treatments, we need PK and safety data on shorter regimens, both for drug-susceptible and drug-resistant TB, but also for prevention. We need better vaccines for young children. We only have the BCG, which is having a role in preventing severe forms of TB, but it doesn't really do much to prevent TB in general. Also, one problem that we have is that traditionally we are reporting on children and adolescents under 15 as children, but actually that definition doesn't really align with how TB works in children, because there's quite a difference in the presentation of TB in children compared to adolescents. So if we would generate data in trials to better align with the clinical definitions, that will also really help to make recommendations that are better targeted at these age groups. So children under 10, and then adolescents 10 to 19. We have lots of key actions, as Maureen and Leslie already mentioned. I won't go through all of them now, but I encourage you to look at the roadmap and download the document. And just to focus on key action number 10, that's the last one because there are 10, which focuses on research and development. So this key action calls for investments in TB research and development for these groups. And these investments really need to be in line with the disease risk and burden. Currently, we are only investing about 8% of all the money that there is for R&D, whereas children and young adolescents make up 12% of the disease burden. So we need more money for this age group. We also need evidence on diagnostic tests, on computer-aided detection, on the integrated treatment decision algorithms. We need studies on new biomarkers, to different type of tests to find TB disease, and also the response to treatment. As I said before, we need to align those age cutoffs in clinical trials with the recommended age groups. We need to close the gaps in PK and safety data. We need to initiate pediatric investigation plans for new TB drugs much sooner. And I'm sure Tony will provide some more detail on that. We also need to facilitate data collection on TB in pregnant and postpartum women. and linking that to how well their babies are doing. Then we need to have a sound pipeline of studies to look at vaccines for children, adolescents, but also for pregnant and postpartum women. So there's a whole list, but we need this to move forward in TB and in children and adolescents. So we need your help to implement these 10 key actions at all levels of the healthcare system and really to end TB in children and adolescents. And we always say we can do it, but as Blessy said during the launch of the roadmap, we need to say we will do it. Thank you very much.
Thank you so much for highlighting those gaps. And next, we would have the approach that is being proposed by Dr. Anthony Garcia-Prats. He needs no introduction. He's a pediatrician with extensive experience in clinical care, programmatic management, and research, especially MDR-TB.
All right, good afternoon. I feel like I'm the very last presentation of the conference. It's good to stick around. I don't know if that's an honor or not. So I'm going to be presenting on something called CHEETAH, which stands for Chasing Expedited and Equitable Treatment Access for Children for TB. And one of the exciting components of this conference, I think, was all of the new information, new studies, new trials about new TB drugs and all the potential those have to improve what we do, better cure, shorter treatment. I mean, it's incredibly exciting. But what you may have noticed is that there's been very little discussion about children and access to those new TB drugs, almost none. And this is business as usual, and we intend to change that. So this is the problem statement that the CHEETAH Task Force and Initiative is intending to address. So there's a large global burden of TB and drug-resistant TB in children. We've heard that already even in this session. Better treatments and regimens are needed, and it's really new TB compounds that have the potential to transform how we're preventing, how we're treating TB. But pediatric evaluations of these new medicines have been very delayed, and I'll show you that on one of the subsequent slides. It's taking much too long for children to be able to access these medicines. This results in preventable morbidity and mortality in children with TB, and this should not be acceptable to anyone. This will persist without additional investment in innovative approaches. There's no reason to think this will magically change unless we act to do something different. So it's important for all of us to be on the same side. If we're advocating for including children appropriately in TB research, what should we actually be advocating for and what should we actually be doing? And it's good to know that actually we don't need to demonstrate that a TB drug works in children if we've shown that it works in adults. It will kill TB in children if it kills TB in adults. And what this means is that we don't need to do large efficacy trials in children with new TB drugs. It's not needed. We can extrapolate the efficacy from adults to children. So that's very useful. We don't need to advocate that these big studies are done in children for every new TB drug. But that is assuming some things. That's assuming that we know how to give that medicine to children in a way that gives the same amount in the child as was seen in those adults. You can imagine if you give a medicine to a child and you get much higher levels in the child, that may result in more toxicity. If you give a medicine to a child and it gets much lower levels than we're in adults, it might not be as effective. So we can extrapolate that it works in children, but we have to make sure we're giving the right amount, the same amount that adults are getting. So it means we need to study the pharmacokinetics, which is just what the body does to a drug when you swallow it. It's how the body uses it, how high the levels get. We need to know the dose that gives the right amount, and we need to be sure that it's safe in children at that dose. Usually it is, and often children tolerate the medicines even better than adults, but we need to check that in studies, and we need to make sure the formulation is there and it's acceptable to children and their families. These are relatively small studies. 40 to 60 children often is enough to answer these questions. But planning for these needs to start much sooner than it is. It needs to start when the TB drugs are entering into phase 2 trials in adults. And if you've seen any of these presentations this week, there's multiple drugs that are in phase 2 studies in adults, and still this work has not happened yet. The pediatric trials need to start when the drug enters into late phase studies like phase 3 studies in adults. So this is what we've seen to date. And this timeline is showing time in years, and the star shows when a drug was approved for use in adults by a stringent regulatory authority like the FDA or EMA. And so let's look at what's happened for the pediatric studies. The open donuts show when the pediatric trials were started. So let's look at Delaminid. The pediatric study of Delaminid opened 1 year before it was approved in adults. That's actually pretty good. That's kind of what we would aim for. But it took a very long time to complete those studies. It took another 8 years. So it was 7 years between when children could access this drug after when adults have been using it regularly. What about for rifapentine? 5 years after it was approved for use in adults, the studies in children finally opened. And it will take at least another few years. It's just becoming available for children across the age spectrum. It's taken 9 years. For bedaquiline, trials started after 4 years after it was approved in adults, and it will take 13 years or maybe even more before those trials are done and children across the age spectrum can access bedaquiline. And then for pretominid, it is the same situation. We're not learning our lesson, are we? 3 to 4 years after it was approved in adults, the trials have just started in the last month, and they will take some time. So this is the situation that we think is unacceptable. Why? What are the root causes of these delays? Well, obviously, the trials are starting too late. These companies aren't having a lot of incentive or pressure to do the work in a timely way. There's delayed planning that needs to be done ahead of the trial starting. A formulation needs to be made. Some special toxicity studies need to be done. And that is starting too late. This is what happens at the last session. There's uncertainty sometimes around the optimal design. There's limited site capacity, at least to date, for places that can do these kind of specialized trials, even though there's a huge amount of potential. Then once the trials start, you saw how slow they're taking, right? They're taking years. So these are very inefficient trial designs. We can do better. We need more sites that can do this work, and they are there. There are experts, there's disease burden, but we're not engaging with these experts in places that have a lot of TB. And we're doing things very efficiently. One study with one company at a time. We start, we stop, we plan something slightly different for another. It's very inefficient. And we've seen these delays with just these few drugs, right? Bedaquiline, Delaminid, pretominid. What are we going to do when we need to study 10 drugs, 12 drugs? All these exciting compounds, and these problems and delays are going to get worse. They certainly won't get better unless we are investing new resources, investing in innovative approaches. So that's what spurred the conceptualization of this CHEETAH task force. It stands for Chasing Expedited and Equitable Treatment Access for Children. It is a multidisciplinary group with the expertise and the mandate to think about this. There's been no group that had the mandate to think systematically about these issues and be proactive in engaging with stakeholders and advocating and developing the science and doing the work. This was convened in November of 2022 with funding from the WHO's GAP-F. The aim is to accelerate pediatric development and optimization of TB medicines. And we've already begun doing a number of important activities, and the objectives of the task force were to map and build site capacity, to do these trials in children because that's a major bottleneck, to engage proactively with drug companies to advocate for the work, and also to say, this is the studies that need to be done, to provide technical expertise to make sure we're doing this efficiently, and then plan for an innovative platform trial, a way to, we think, do these studies much more efficiently. And this is what that platform trial might look like. It would be a partnership between CHEETAH and sites, as well as with the companies that own the TB drugs, focused on doing these specialized trials in children, not for science, but to get access to these drugs, get these drugs approved in children, and doing the kind of studies that need to be done, these phase 1 and 2 trials focused on pharmacokinetics, dose, and safety. What do we think is the potential impact of CHEETAH? We think we could cut in half the time from approval in adults to approval in children, and that's a very conservative estimate, from 8 to 9 to 10 years down to 3 to 4 years. We think it's very realistic if we're serious about this and we invest resources. This would reduce morbidity and mortality, improve equity to this priority population, and we also think these issues are cross-cutting across diseases, and there's lessons for other disease areas from what we do in TB. What about CHEETAH in the community? It's critical for the community to give input into the CHEETAH concept, and Gloria Moses is a representative of the task force. From the very beginning that this task force was conceptualized, community perspective and input has been considered and is critical, and we want to continue to consider that. The community are obvious advocates for equitable and timely access for children to these new treatments. It's very important that community is being the voice for children who can't often be their own voices. It's critical for the community to advocate for increased funding for CHEETAH and similar research in children. It's not a priority if you look out at where funds are going. And then lastly, for the community to demand that these owners of these new compounds, companies, other partnerships are prioritizing children and complete the required pediatric studies. If we don't demand it, they're not going to do it. That's all. Thank you very much.
Great. So thank you everyone for staying until the last 5 minutes, which you only have for like 2 questions. So thanks to all the presenters again. So there's one that's on the portal, and that's for Maureen. From the presentations, we saw that there's a lot of stigma and discrimination, and of course, mostly to lack of information. So can you speak a bit more and recommend some strategies for treatment literacy of patients, parents, caregivers?
Yes, thank you very much. And so in terms of increasing community awareness and knowledge, the first thing I would think of is for a program to ascertain a situation analysis, to analyze what the components are in the community, the gatekeepers in the community, the facilitators, the enablers. And this will enable any program to provide targeted information. I'll speak to an example from Uganda where we have done a lot of research, and health-seeking behavior is like very, very low. So people will wait until they are really unable to, go to work, unable to fend for their families, and that's when they will seek care. So in that case, in such a scenario, we have attempted to go out into the communities to meet people at their household level, to meet people within their homes, and provide information to them. And we are doing that twice a year, where we do mass campaigns. So every March, every October, we go out into the community, household level, to try and educate the community. I'll also call on Blessy to talk about treatment literacy. That's one of the areas that she is really passionate about. But for treatment literacy, it's important for the caregivers to first of all understand the disease itself, and to also appreciate the fact that TB is curable, and how to administer the medicines, and how they'll be able to support the child. Developing materials in the local language in a simple manner, what the patient will be able, or the caregiver will be able to understand. Many times we have all these materials that are high level, and the community does not even understand what they are talking about. So how do you bring that information from high up there to the community? And I think that is one of an approach that quickly comes to mind, plus all the other maybe media opportunities. In my country, we do have megaphones, we do have local radios, we do have community activities that bring people together. So those are opportunities to really build upon.
Okay, I'm not sure if our time is over, because I'm seeing somebody standing there taking time. Okay, do you want to add something to that?
Okay. No, very quickly, we all talk about how far we've come this morning's session. There was great celebration of how much we've achieved, which probably is true, but on the ground, when you look at communities, actually there isn't that much of information that is available. We tend to see that over and over again. I don't want to be comparing with HIV, but every person who's on ARVs is able to say the names of the medicines. The same person is on TB medication, has no idea. So this is not the failure of the community, it's our failure. That we haven't been able to make information literacy available in a way that is easily acceptable, understood, and owned by the community. Because information gives you power, it's empowerment. So if we're talking about community empowerment, that should be the first thing that we think about. Look at the advertisements. You know, a simple thing as a soap. There's so much energy, resources put into making people understand even things that they don't do. You know, in India, they keep saying it'll make you fair. You know, so what I'm saying is that we don't seem to focus on making people understand TB in a way that is important. Thank you.
Let's see. Any other?
Yeah, thank you. I really appreciate all the presentations. I think it's excellent, and I want to build on the last few points. I think what's often forgotten is that we don't necessarily engage the providers that are in the community. The people that are in the community, and where we know that we're really missing in childhood TB is many of the private sector. And I'm not talking about private healthcare clinics. I'm really talking about the pharmacy or the local informal provider or the practitioner on the corner who's during the day in a public hospital but in the evening has his private clinic. They need to be engaged and have the tools and have the information and how to break through that they actually receive the testing, they receive the information, they receive the guidelines, they're being engaged by the program to get also the treatments. I think I wanted just to know if there's any experience from your side or any areas where maybe to break through those access barriers when we talk about equitable access. Is that being addressed, or do you have examples? Because I would love to hear so that we can help further spread those models.
Anyone? Someone? Lindsay has.
Petra, I think for Cheetah, we've been thinking a lot about how to enroll more children in research, because part of the reasons the studies are so slow is that kids are kind of hard to find and diagnose, right? Like, we know we're not doing a good job through the traditional way. And so I think it's a really interesting question as we're thinking about setting up trials and building capacity to be able to enroll kids more quickly so that they can have access to these new drugs, to think about how to connect sites who are enrolling kids with private providers who they may be seeing first before they go to a more public or connected clinic. So yeah, I think it's an excellent point to think about in the context of research. I don't have an answer on the program side, but just wanted to say.
Great. Oh,
Maybe just to add, I think it works both ways. I mean, providing information to all the providers, and that may include traditional healers as well, for example, in the African setting. But I think what is also really critical is creating awareness at the community level so that people are, caregivers, anyone in the community is aware that children can actually also get TB. And I think in Nigeria there's been very good examples of creating that awareness because people were actually not aware that children actually do get TB. And then explaining how it presents and that it's also preventable, so that there is increased demand for services. Also to say, you know, there's someone in my family who's been diagnosed with TB. Now I have 2 young kids here and I need them to get TB preventive treatment. You know, so if we don't generate that demand, we will never get there. So I think it works both ways in creating more awareness, both especially in the community, creating demand for service, and then making sure that all providers can actually provide these services. And then I think integration of services is very important as well, decentralization to the primary healthcare level, so that we can provide the services closer to where the children, the adolescents and their families are. Thank you.
great. Demand creation has come up. Anyone else? Or we have the advantage of being the last one, so we're not being kicked away. Any more thoughts before I hand over the mic? Great. So, again, congratulations for making it to the end. Thank you so much for joining us, and another applaud for the presentations, and of course to hear about cheetah. Yes, so thank you very much. Enjoy Paris.